so the patient's in the chair, he's scooted back. These patients, we're doing transfers. We are not ambulating, we're not walking. I can't sit him at the side of the bed and walk away, right? We just talked about if we get them sitting at the edge of bed, my hand is on them until they are in this wheelchair, the whole time. So that being said, the only time I can have hands and like be away from this patient is when he is scooted back in the chair, both armrests are on, leg rests are on. I can walk away, I can do what I want. If I need to go get my gait belt, get a slide board, get the pillow out of the way, reset the room, I can do it while he's in this orientation. So I'm gonna plan ahead, getting him back to bed. I'm gonna get the pillow out of the way. Make sure you know where the head of the bed is so we can aim and kind of land him in the middle so that when we lay down, he's high enough up in the bed. So to transfer this patient to bed, we need to orient this wheelchair at a 45-degree angle. 45-degree angle, like this, okay? Aiming in the middle. Picturing if his feet touch the floor, we stand up and we rotate, where will he land? I always want to err on the side of him being higher in the bed than lower, especially in the hospital setting because patients always slide down. You raise the head of bed, they're already down at the foot of the bed. Okay? So he's here, I'm gonna lock both brakes. He's at a 45-degree angle. There's really only one transfer that you're gonna do that does not put the wheelchair at a 45. So when in doubt, put the wheelchair at a 45. What that does is gets his fulcrum, where he's pivoting around, which is his feet, closer here. If we're at a 90-degree angle, his feet would then be out here, and then if he sits, either we're missing the bed or we have to find some way to get him back here to the surface.
That
Okay?
and the wheels of the wheelchair with the bed.
I'm sorry?
The wheels of the wheelchair with the bed, if it was 90, you wouldn't be able to, it would have too much space between.
Right, yep, exactly. So we want to get as close, again, we're not ambulating, we're not taking real steps, we're just pivoting. We want as close as possible to make sure it's safe. Okay, so we're here. We've got a patient that only has one leg affected, right? The left leg's affected. We said he had a femur fracture, he's fixed, and he's on some good pain meds. He's not in a bunch of pain right now, we lucked out. We're gonna transfer him back to bed. He's been sitting up for an hour. So we always want to transfer to the strong side, okay? Right side is strong, that's why we're transferring this direction. Where we're going is on the strong side, okay? Versus the weak side where that leg may get in the way if we're moving towards it. Can you always set up the room that way?
No.
No, especially when you go home. When the patient goes home, they need to know how to go both ways.
That and
Transfer.
toileting and showering.
Toileting based on the environment, so limiting. In an ideal situation, which is what we're replicating with these practicals, we always want to transfer to the strong side. Okay, so that's how I've set it up. Right leg is strong, his arms are strong. Now we need to get the footrest out of the way. So left leg's affected, I'm gonna leave it on the footrest. Instead of taking that one off first, I need to get the leg rest that's closest to the bed off. I already locked the chair, that's just so I know that it's locked, and then I can sequentially go from there so I don't forget. Also so I can keep the 45-degree angle. So I'm down here, I'm gonna unlock the side closest to the bed, bring that leg back up here. I'm gonna pivot. That way that wheel stays so I can always just pivot him right back and I know it's a 45. This leg is unaffected. I can ask him to lift it up. Go ahead and lift that leg. Take some time if you haven't messed with a wheelchair before. Play with it. Anyone that does know how to manipulate a wheelchair, take armrests off, take leg rests off, feel free to help them out. We will have a lab on wheelchairs next time you're here, okay? So we have a little toggle, you flip it, and then you swivel it out, and it sits on two little pegs, and you just lift it up. With these, I'm getting my patient back to bed. Do I need these again while I'm with my patient?
No.
No, get them out of the way. Okay, make sure they're not anywhere where it's gonna trip you or the patient up. If we went from bed to wheelchair, I'm gonna need them off the chair, but I'm gonna need them close by so that I can put them back on. So we'll do that probably after lunch, back to bed. So we're gonna know both directions how to transfer a patient, okay? So this is the unaffected leg. I just took the leg rest off, go ahead and lift that foot. I'm gonna pivot us back. Boom, we're back at a 45-degree angle. Okay, there we go. This I don't have to mess with because I can just support this affected leg and then lower it down nice and slow, out of the way. that's why I lock the chair fully before taking the leg rest off. That's why I take the leg rest closest to the bed off first. So now we're here to get this patient up. We're standing up, and it's called the standing assisted pivot transfer. So I am going to be blocking this leg. Blocking is a way that we stop a limb from buckling. So when we stand up, if he's got a leg that's weak, it has a tendency to lose strength and buckle, and the patient will fall. So what I'm going to be doing, with my foot outside of his, my knee will cross inside his. My shin is making an X with his. It's not my kneecap on his where they're round. One, it won't feel comfortable. Two, it's not stable. You could lose your block, okay? So it's my shin is making an X with his, okay? Notice how I'm back. If I'm up over the patient like this, I'm pushing him back actively into the chair. There's no room for him to stand up. I'm gonna be back on my stance leg, right? All my weight is shifted back. This leg is here just in case. You have to maintain contact, but I shouldn't be actively leaning against him because he's not gonna be able to stand up if I do that, okay? When you and I go to get up out of a chair, we're seated all the way back in. How do we do it?
Scoot your booty forward.
Scoot your booty forward, okay? So, could we stand up from back here? Some of us, yes.
More
It's a lot
power.
harder, especially if we have an injury, we're in pain. So, this patient, do they have the strength to scoot forward? Yes.
Knee blocking.
Think back to when we had the orthopedic patient with the long sit method. When did I gain trunk contact? Before we moved or after we moved?
Before.
Before. So he scooted back in the chair. When should I put my hand on his trunk?
When he starts moving.
Before he starts.
Oh, before.
Before, yep. So before he brings his back off of the chair, I need to have a hand on his trunk. From then until we are laying down in bed, okay? So at all times, we need to maintain at least 1 point of trunk contact.
Whenever I have him scoot forward, I'll block the knees.
Yes,
My
yes.
hands.
So I can be here, and I don't want to be actively pushing against him because then he's not going to be sliding forward. But if I'm here, I can be ready to accept his shin like against mine. So go ahead and scoot yourself forward, right about there.
Okay.
And I'm ready. That way I know he's not going to go too far forward, and that's kind of giving him a target for, okay, that's how far I want you to come. Okay? So we're going to reset, go back. Right now, the leg rests are off the wheelchair. The only rule right now, because both armrests are on, he's scooted back. I don't have to have a hand on him, but I need to stay in front of him. If I forgot, oh gosh, the gate belt, it's across the room. If I walk away to go grab it, he could potentially slip out the chair, he could fall forward, he could try to get up on his own. That's a safety risk, okay? Let's say I did forget my gate belt, it is across the room. Put the leg rest back on, it's gonna take time, but I'd rather you do that than lose points for safety, okay? You go get it, put it back on. So leg rests are off, you just need to be in front of the patient in general, okay? As soon as before he scoots forward is when your trunk contact starts, and it needs to remain until he's safely in bed, okay? The other thing is the caster wheels. If we have a larger patient and they scoot forward to the edge of the seat, some chairs will tilt forward depending on the weight of the patient and how much force they're pushing down on the armrests. Obviously would not be safe. So we care about the orientation of the caster wheels. The goal is to increase the base of support, the distance between the caster wheel and the drive wheel. That way the chair is more stable. You see there's a little bit of an angle to this frame for the caster wheel. Right now, what orientation would you say it's in? Is it facing forward, sideways, back? It's back. I would say it's facing back. It's subtle, but that frame is facing backwards. So we can do better. We can either go side to side, or you can go anterior. This is obviously the most stable because it gets that caster wheel out in front, widens the base of support of that chair. It's more stable. For any transfer that we're doing, depending on where your feet need to be, the patient, so I'm gonna go forward with this. You have to do both wheels. There we go, thanks. Okay. The wheels touch the floor. I don't expect you to walk across the room, because we can't leave our patient, and hit hand sanitizer, but I want to hear you verbalize, I would hand sanitize. I would do something, or I wouldn't touch the wheel, and then go put hands on a patient, okay? Just so verbalizing it, just so we're on the same page of what potential infection control risks are, okay? Now the chair is in a safe position, it's ready for him to scoot forward. I'm gonna ask him, he's strong enough, go ahead and scoot forward, okay? I want you to bring your legs together, okay? And we're gonna move him as close as we can to the surface. So instead of his leg being out here, where we're gonna have to span this amount of distance, I'm here, I'm blocking his leg. Am I putting a bunch of force against your knee? No, I'm just there in case he buckles. Okay, gait belt, it's gonna be an underhand grip. So I'm gonna hook my fingers back here, behind the patient, or on the side, not in the front. But it's an underhand grip, that way if he falls or if I need to pull up, the gait belt sits into my hand versus this, where it can slide out.
Are we doing a stand pivot?
We are, we're doing standing assisted pivot transfer. So I'm here, my face should be here, looking where the patient's going, okay? So I'm here, stand up on 3, 1, 2, 3, up. We're here, stand all the way up. Good, you can have his hands down to the side, but we're gonna take pivoting steps. First gonna pivot, and then we're gonna sit, reach back to the bed, and then sit slowly. Okay, so this patient, thank you. This patient has one leg affected. We stand up, we take little pivoting steps like this, and then we sit down. My shin does not leave his, but I'm not applying a force unless he needs it. Yes?
I mean, like when I've done this in the past,
Yeah.
It's usually a little more beneficial to have a wider base instead of like feet touching.
Yes. Depends on the patient and if they have the ability to pivot enough to get back to here.
Okay.
Yeah. So as long as your shin stays in contact with theirs, that's what we're looking at as far as safety. If we stand up and your shins separate, at that time, if the patient were to buckle, if they were to fall, you aren't adequately blocking their leg and they could fall, okay? So that's why what I'm looking for is your block needs to stay in place through the entire movement. So you're gonna have to practice it and it's gonna feel awkward. It's gonna feel like you're up in the patient's face. That's why you notice when we stand up, I weight shift back. That way I give him room to stand up and my leg is forward, staying in contact, and we're just kind of pivoting like this. Then when he sits, I didn't just let him sit. I squat with him until he's seated, and then where did my hand go? One hand went immediately to the shoulder before my other hand came off, right? Because then we would do that mobility, okay? Standing assisted pivot transfer, okay? So, any questions on it? You wanna see it one more time? Okay, we'll do it one more time, then we'll go to lunch. And we'll
So
practice
both
when we
feet
get back.
moved on this one?
So, yeah. First we're here, go ahead and scoot forward. Okay, we'll move our legs a little bit closer to the bed. Okay, and they don't need to be, we have a transfer that we'll do where their legs are glued to each other. We just need to make sure we've started kind of like rotating so that our knees are closer. That way when we stand up, we're just kind of pivoting. Okay, but they don't need to be like this. That's a different transfer. So we're here, my foot should be outside his, my knee is inside. The reason we don't do the opposite, go ahead and spread your feet a little bit. The reason we don't do our foot inside, my knee outside is, my patient is not in front of me. Okay, I need to be in front of him so that I can help him stand without me twisting my spine. So this block should be, my foot is outside his, my knee is inside. Underhand grip on the gait belt, either lateral, if not even better, is behind the patient. Do not be in front. You're not gonna have enough support. Okay, we're gonna stand up on 3, all the way up. 1, 2, 3, up. He stands all the way up, and then we're gonna take steps. And then reach back to the bed, sit, and then hand comes up, and then we progress with bed mobility. Okay?
It almost like you're, I think you just said too, it almost looks like you're moving.
Yeah, I was gonna say,
Yeah.
because I'll put my foot on the inside, because then that way with my heel, I can turn their foot.
So for a different transfer, yes, this patient has the ability to rotate it. It looks like I'm pushing him and like turning him, but he doesn't need it. I'm just